All right. Welcome, everybody, to this Hopkins Hour special for National Pain Week 2024. My name's Nick Aitcheson. I'm the director of the Metro South Pain Rehabilitation Centre. I'm a rehabilitation and pain physician, and I come from a background of chronic musculoskeletal and pain physiotherapy. So we've got a great online seminar today. It's called Making Our Best Guess of the World, How Personal Narratives Help and Hinder the Chronic Pain Experience. We would like to extend a warm welcome to all Hopkins Centre members, partners and collaborators who are joining us today. Before I begin, I'd like to give an acknowledgement of country. We are privileged to be meeting here in Meanjin, Brisbane, on Aboriginal land traditionally cared for over millennia by the Yagara and Turrbal peoples. We pay respect to elders and their wisdom and culture past, present and emerging. We acknowledge that sovereignty was never ceded and that this was always and always will be Aboriginal land. We acknowledge the ongoing negative health impacts of the disruption, dispossession and displacement of First Nations people and the colonial systems that have destroyed and to continue to destroy wisdom and culture related to land, songlines, and traditional practices. Through collaborative intent, we seek to create the best outcomes possible for First Nations people and all Australians. We also acknowledge the widely varied and deeply experienced cultural backgrounds that are brought from all over the world to this meeting, and we pay respect to these traditions in recognition of the wealth that they bring to our community. So thank you very, very much for all tuning in. I've got a few housekeeping points to go through. So we are aware that internet connections will vary in this online environment. So if you experience technical difficulties, please feel free to put a question into the chat via the toolbar. And one of our events team will do their best to assist you if needed. You can leave the Teams event platform at any time and return to it without losing your place. Live captioning is available for this event via the link that our team are putting into the chat now. And please feel free to ask questions at any time throughout today's event, and to do this by typing a question into the chat box. All questions will be moderated by the events team and addressed towards the end of the session. And if typing your question into the chat box is not available, please feel free to raise your virtual hand by selecting the raise hand button, and you'll be invited to ask your question by unmuting yourself at an appropriate time. So we've got a wonderful lineup of speakers today, and they are Kim Talaber, Mark Berridge, Lisa Cox, and Hannah Kennedy. And I'm just going to give them the opportunity to introduce themselves now. So Kim.
Thank you, Nick. So hello, everyone. Thank you for tuning in. My name is Kim, and I am a physiotherapist by training. That's what I did before I started my PhD. So I'm also a PhD candidate in this space. Specifically, part of my PhD is funded by a seed grant from Hopkins Centre, and it's looking at the experience of someone with spinal cord injury related pain, and looking at ways to understand first and then possibly intervene with some kind of brain-based management. So that includes some virtual reality. Very excited to be on this panel and looking forward to our discussion. I'll hand it off to Mark next for his intro.
Thank you, Kim, and thank you everyone for joining. My name's Mark Berridge. I'm a speaker and author. I like to call myself an accidental author. I had a big spinal cord injury in March 2019, which set me on a journey of being able to write about my journey to share with others and help them find their own inner strength and resilience. I'm very excited to be on the panel today. I'd like to hand over to the lovely and inspiring Lisa Cox.
Just on mute, Lisa, still.
Yeah, someone always does it, and that's been me. Hi everyone, my name's Cox, and I've had disabilities for over 20 years, or nearly 20 years now, visible and invisible. And chronic pain's been a really big part of my life. So I'm excited to be here today to share my experiences with you all. I do a lot of work with public and private healthcare facilities, directly with the clinicians, helping them to provide better outcomes for patients, I suppose. And again, a lot of that is showing my own experiences, what's worked, what hasn't, and how the experts can help you all. I'll hand over now to Hannah, I believe.
Good afternoon, everybody. Thank you, Lisa. Yes, my name's Hannah Kennedy. I'm a senior occupational therapist at the Gold Coast Interdisciplinary Persistent Pain Service. I really, really enjoy and am passionate about working with a team to support people with persistent pain and chronic pain issues. In addition, we've been embarking on research with our team. Some of our research has been looking into the personal factors that are involved in someone's pain experience. These might be things within their world, within their activities, within their own day-to-day life, and looking at the factors that can help decrease someone's pain protection from a biopsychosocial approach. Our team's also doing research in regards to the use of virtual reality for helping people to understand pain science, pain management, and really help people to move forward with their own pain management. So look forward to joining the team on the discussion today.
All right, thank you, everybody. So we're going to start off with some presentations. I think I'm first up. I've got a few slides here. So I'm going to take control of the presentation, and hopefully this works. It looks like it has. So we're essentially talking about what the pain experience is, and especially the chronic pain experience, and why that is maybe different from how we perceive acute pain, and also why pain is at its heart a perceptual experience. So I'm going to give a brief overview of this lens on pain, and it is going to be very brief, probably about 10 minutes or less. So it's a bit of stuff to get your head around, but hopefully I can make it simple so that we can get something useful out of it as a way to work with people with chronic pain. I've included a little picture of Alice in Wonderland here because there are all sorts of perceptual things going on in Alice in Wonderland, and things that are magnified, things that are minimized, and things that are scary, and things that are exciting. So there we go. So traditionally we think of sensation, or are taught that sensation is the generation of or the effect of energy in the environment being picked up by our senses and then relayed through to different parts of our brain where we make a picture of the world. And so the example here is of a tree where light waves bounce off the tree and then they're transmitted into nerve impulses which go to our brain. And essentially what we do with that is we make up a kind of a mosaic of the world around us, so that this continuous feed of information from the energies in the world around us is brought in by our senses, and it's built into this kind of continuous picture of varied resolution, which changes as we move through the world. Now, a different view of perception has been gaining traction over the past 10 years through cutting-edge neuroscience, functional brain imaging, and various EEG experiments. This is called the predictive processing model. And essentially what this says is that we're probably born with some things which are a model of the world. So we know that, for example, baby monkeys are scared of snakes, and cats have various things that they go for and go away from. But through our life, we make a model of the world around us, and which bits we like, which bits we don't like, which bits are safe to interact with, which bits are dangerous to interact with. And also we make a model of how the world feels, looks, behaves, everything like that. And the job of our senses in this model is actually just to check in with that model. So we've got this pre-existing model that is partly inborn and partly created by our experiences over time. And what our senses do is they check in with the model, and if the sensory input matches the model, then the sensory input is ignored because the model is thought of as accurate to the world. However, if the sensory input contradicts the model, then the sensory input is weighed, the strength of the sensory input is weighed against the strength of the model. And if the mismatch between the sensory input and the model is strong enough, then the model is essentially revised to match the new sensory input. So then the new model is concordant with the new sensory perception or sensory information regarding the world around us. So in this model, our perception becomes all about the model that we have created over time. Okay. So the model that we, in the predictive processing theory, the model of our world is called our priors, and our senses is referred to as our posteriors. So our posteriors check in with our priors, and if that's concordant, then everything's great. But if there is a mismatch, then we decide whether we need to modify our priors or not. And the priors continue to form our ongoing modifiable plastic best guess of the world. So a brief note about pain. So pain is something that helps us to avoid damage to our bodies. It's protective. We used to think of pain very much from a neurological standpoint. But then we realized that this is quite limited because pain is affected by a whole lot of different things, including cytokines in your body. It's affected by your hormones. It's affected by your immune system. And so now we think of pain as a neurological, immunological, and hormonal or endocrine model. And all of these things interact with each other. All of these systems interact with each other to change our experience of pain. And so in this model, or with this knowledge of how pain works, pain becomes not just all about nerves, it becomes about our whole body, and also potentially our model of pain and our priors. And this is maybe a little bit of a controversial statement, maybe exists to some extent in our immunological and hormonal systems as well as our neurological system. But essentially, pain promotes behavior, or should ideally promote behavior that leads to ongoing survival of the organism, and hence evolution has selected for pain along the way as something very useful to make sure that we pass our DNA on. So why does pain become difficult from a predictive processing point of view? Why do people get into strife with chronic pain, and why does our protective system kind of spin out of control or become over-amplified? So remember from the earlier slides, the way that the priors are modified is by posteriors, so the way that our model is modified, is by our senses bringing in information that conflicts with that model. But pain is not a one-to-one sensory input. Pain is something that is processed very highly within our body. It can be amplified, and the experience of pain, although it's experienced as a sensation, is the output of many, many different things going on. And it's the output of that prior itself, and the priors, those priors saying, hey, you need to protect this part of your body. You need to protect yourself. The world's a dangerous place. So even though we weigh it up equally as a sensation similar to eyesight or hearing or smell, the actual process that's going on behind that is very, very different. There's amplification, there's changing of areas of perception, there's a whole lot of emotional baggage that is laden with it as well. But the output is basically something that's like a sensation. So we get this thing that we say, oh, well, my sensation is that this is bad pain. My sensation is that it's threatening. And what that does is it reinforces the prior that says we need protection. So that prior, instead of getting normally backed off and eroded, can go into what we call a positive feedback loop or a vicious cycle, where the posterior coming in is actually the modified pain experience. So it gets reinforced and reinforced, and you get ongoing immunological and hormonal reinforcement of it as well, and things get worse and worse. So that's your chronic pain cycle from a predictive processing point of view. You get this overvalued prior, this overprotective prior that continues to get reinforced by a misinterpreted posterior. So we don't all get chronic pain. Why do some people get chronic pain and some people don't? So sometimes the perceived threat can be so huge that the prior is becomes laden with excessive meaning. So if a brickie strains his back, that means he might lose his house or his family or his occupation, as opposed to the lawyer who sits at a desk and writes notes. So the threat is much greater. If the world is generally threatening, so people with generalized anxiety will often go into chronic pain states more easily. If the world has been proven to be harmful in the past, in terms of post-traumatic stress disorder, and some people, for whatever reason, have a conceptual bias towards things being threatening or a need to be overprotective. So there are multiple studies where neutral words have been given to people with chronic pain and people without chronic pain. So, for example, the word mass would be interpreted potentially more threateningly by people with chronic pain as a tumor or something that's going to push on something, whereas with people without chronic pain would be interpreted as something to do with weight or gravity, or maybe a church service or something like that. And then there's this thing which is often created by medical practitioners, this fear around the fragility of a certain body part. So your desiccated disc or slipped disc, and this idea that those things need to be particularly protected. All these different conditions create strengthened overprotective priors. So how can we change these things? If we're stuck in this kind of feedback loop of this painful sensation coming, being experienced, and then that strengthening our model that our body needs overprotection, how can we chip away at that sort of thing? We can create a safe environment for people to move. So physiotherapists can reassure people, show people how to breathe, and show people how to experience pain-free movement, and that can create a useful mismatch error, which can allow for modification of those priors. We can address that as ideas of the framing of body parts as fragile. So we can use physical examination, and we can explain people's scans to them. We can explain that a lot of those scary words are not actually quite so scary. And we can address some of the things that lead to that overprotection, so anxiety, trauma, poor social support, and financial issues. And we can also give people a feeling of control over their lives, so regaining identity and agency in areas unrelated to pain. So when you think of pain in this way, it becomes more important to address the internal model and perception of pain, and less important to address the peripheral drivers of pain. So pain and nociception are very, very different things. Acute pain and chronic pain are very, very different things. So I thought I'd leave everyone with the results of a decade-long study that was done by the Neuro-Orthopedic Institute down in Adelaide, associated with the University of South Australia. And this is basically people who've been through chronic pain programs, education programs, and have got better. This is the 8 most useful messages that they took away from those programs. So they said pain is a protective feeling, and we could spend a whole hour talking about these 8 points. So I'll just go through them relatively quickly. Pain and tissue damage are poorly related. When it comes to pain, everything matters. So your sleep matters, your diet matters, your friends matter, your ideas about pain matter. Everything impinges on your pain experience. When pain persists, it becomes overprotective. I can retrain my pain system to be less protective. So we can change those priors. We can change that overprotective model. Learning how pain works is an effective treatment. Active strategies are better than passive strategies. So getting involved in your own pain treatment is much more effective than having people massage you or stick needles into you. All pain is real, no matter what is causing it. So our pain experience is real and should be respected, no matter what the cause. I think that's the end of my little bit. I'd like to hand over to Kim now, who's going to talk a bit about her work with spinal injuries and pain.
Thank you, Nick. Yes, that was, I totally echo that we could spend probably multiple hours, I reckon, giving us some snacks and some hydration on those last points. The purpose of my talk is, I'm just going to try to get myself. Yeah. Okay, great. My presentation, when I was approached to do this panel, was if we're talking about kind of beliefs and the importance of personal frameworks, I think it's important to share with you some of the things that I've been finding in my research within my PhD. In particular, one study was a survey that evaluated 95 people that had spinal cord injury related pain of some sort. Now, this survey, it was quite broad, so I'm not going to spend time talking about all of these domains. I'm going to narrow in on the first one, but very happy to be contacted after this panel if anyone has questions about more of what I talk about. The domains that my survey asked about was trying to get a snapshot of these 5 kind of core areas. So what I wanted to know was people that have spinal cord injury related pain, what do they believe is the cause of their pain? I wanted to know about how bothersome pain was and how much kind of pain contributed to kind of daily quality of life aspects. I wanted to know how people prioritize their pain for recovery amongst other things that they might want to seek recovery for. I also wanted to explore people's beliefs around cure for pain, because that would be interesting to me as a researcher and as a physio. That might give me some idea as to what then people might think is causing their pain based on what they believe might cure it. And then I wanted to investigate what people have tried in the past in terms of treatment strategies. As Nick mentioned in that list, active strategies are really, really beneficial. And there are so many. So I wanted to investigate that as well. But for this talk at the moment, I'm just going to focus on this first domain, which is what do people think is the cause of their pain, and see. As I've started to analyze that data, I have started to pick up on some common themes. And so I'm going to present a couple different themes that I've started to see repeated throughout the sample, and then have a little bit of a chat about each of them. So the question that was posed to everybody was, please describe in your own words how you think your spinal cord injury causes your pain. So I'm interested in that link that people may perceive, if there is a link between having a damaged or injured spinal cord and then their pain experience. So this first couple of quotes: I can't feel anything below my chest, and I get painful spasms and have neuropathic pain. Pins and needles, electric shocks, and burning. What causes it? Movements and touch. I was told the body's nerve signals below the trauma are not reaching the brain with the spinal cord damage. So something along the lines that there's this kind of signal pathway that some sort of impact along the way. The signals can't reach the brain with the damage is interesting. Another quote was, all the pain started after my injury. Feels like everything is asleep and trying to wake up. Every movement of the leg or body feels like you're being poked with pins and needles, or with pins everywhere nonstop. So in these two quotes are some of the very common descriptors that healthcare professionals identify with as neuropathic pain. Specifically, as there's different pain types, and neuropathic pain, the very classically has the pins and needles, electric shocks, burning, poked with pins. So that very much came out from numerous, I would say the most amount of responses had some sort of nerve or neuropathic pain descriptor in them. On to the next kind of theme, which I found quite interesting, is the theme around nerve signals or messages, and the processing of those messages that then relate to pain or lead to pain. So different quotes like, the nerve messages are scrambled. I think it's due to my proprioception, messages up, then the brain being confused and messages being misread due to my injury. Because of being incomplete, the nerve signals are distorted, making even more pain. There is miscommunication and interrupted signals. I think the nerves in my spinal cord are hyperactive. So it does seem like there is some knowledge that nerves are transmitting information, which was demonstrated in Nick's presentation just then, but it seems like that is quite a common message that someone would get throughout the care after they experience a spinal cord injury. And then it seems like that's where then the explanation of why pain happens maybe ends, is that it's just that's messed up, which I guess is, yeah, I would argue is maybe a bit too simple of an explanation, and I can definitely see how that might be frustrating for someone who's experiencing this, because that, to me at least, that doesn't necessarily seem as thorough, but at least I guess there is a baseline potential awareness of that nerves and signals and messages, and that the brain ultimately is the part of the body that is responsible for the experience of pain. So thought that was really interesting, and that came up quite a bit. So that will be good to review a little bit more. Another theme that came out of this particular part of the survey, which was pain as a result of something to do with movement or posture, some sort of time-related activity. So I attribute the pain to stress on my spine when standing or moving about. The pain subsides to a 2 out of 10 when I can remain absolutely still in supine position. So obviously rest is beneficial for this person, for their pain. Another person says too much time in the chair. Another person says, I stand and walk on paralyzed lower legs and feet with AFOs and crutches, ankle foot orthoses and crutches. This causes and aggravates neuropathy based on how long I am up. So pain related to sitting and wheeling, so in elbow joints. So there were quite a few responses that had, yeah, some sort of movement or lack of movement, or too much activity or sustained activity relating to their pain experience. And then there was definitely a theme that was reoccurring that had to do with more abdominal, kind of visceral pain, or pelvic pain. So pain associated with slow peristalsis. Another issue is bladder spasm pain. This person says there's a combination of pain sensations. The worst are in my lower extremities, where it's a freezing burn with a sense of crushing or squeezing. I also have internal pain when there is bladder or bowel that needs emptied. The spasm and cramps cause typical muscular ache along with muscle tightness pain. So this person has done a really impressive job of really delineating their different pain experiences and their different pain types, which I do think is a takeaway from what I'm seeing so far in this survey analysis. Is I think that's really important if you are tuning in and you experience different types of pain. Although pain is this kind of, we want to look at you as a whole person, as a healthcare professional trying to help. It is really useful for us to know kind of the thoroughly your experience. And so I thought that was a nice example of just these kind of different pain experiences that, you know, are all happening in the same person, in the same body, with the same brain. And so it's a testament that especially in someone with a spinal cord injury, with the nature of it being such a complex clinical picture, there are these different types of pain and pain experiences. So multiple pains. Okay, lastly, there was also a theme strongly related to kind of muscle weakness or lack of strength or muscle imbalance, and then along with maybe overactivity or spasm or spasticity. So lack of muscle control leads to the atrophy and weakened muscles below injury, causing those muscles to lose strength and become painful. Another person says spasms, shoulder pain from overuse, other areas from muscle imbalance and overcompensation. Excuse me. Another says caused by spasticity, particularly to my hamstrings and my triceps. So this idea that muscles themselves were a part of what's driving someone's pain. So far, just as it's some takeaways before I hand off to Mark, it seems very obvious to me now that, you know, like I was just saying, many people with a spinal cord injury may experience different types of pain. different pain locations, different pain intensities that can then change and ebb and flow. But regardless of all that, and more, in line with those 8 messages of pain soothing education that Nick showed, all of your pain experiences are valid and they are worth advocating for. So I guess I would encourage you to have that go at really assessing, I suppose, and investigating, exploring the different pain experiences that you have in order to then bring that to like a trusted healthcare professional to have, so that we have a full picture of, the complexity of your experience. That's it from me, and I will happy to answer any follow-up questions in the Q and answer time.
Thank you, Kim. And it's my great privilege to be able to speak today. I'm coming at it from the lived experience basis in terms of pain. I haven't, sort of on my to-do list, I think, to learn about pain some more. So this has been really helpful for me in terms of hearing both Nick and Kim and those experiences. And I was fortunate enough to support Kim in some of her research as well, which I know is going to be really important for a lot of people. So I wanted to start by going back to September 2020. It was Father's Day. I woke up, I would imagine, in the middle of the night, as I often did, with searing sort of nerve pain down my legs and cramps, and just couldn't stop the mind going, as happened, 2:30 in the morning or something like that, and thinking about how life hadn't quite worked out the last couple of years the way I thought it would be, and wasn't looking the same as I wanted it to look in the future. And particularly, I think that, perhaps Father's Day moment crystallized those ruminations, that self-punishment that we can all do at different stages. Certainly I am good at it, of, I'm just not as physically capable of doing the things that I used to do. This has got impacts on my family. It's got impacts on the future in the way that I didn't think it would do. And I guess that, those thoughts just kept going around my head for a couple of hours, and I couldn't do it. And I sort of reverted to what has been, my strategy in dealing with pain quite often, and overall my recovery from a spinal cord injury of March 2019, which was, I've got to get up and take action. I can't just sit here and, I guess, sit amongst the woe. I've got to take personal agency for my situation and do something. Now, some of that comes from desperation. There's implications from desperation, good and bad. But I just sort of thought, I'm going to get up and I'm going to go walk. Right, what's the hardest thing I can think of walking near my house? I live in Coorparoo. Mount Gravatt's 10 minutes down the road. I know that there's a fire break down there. I'm just going to go down there at 4:30 in the morning and start walking up this fire break just to prove I can do things. Wasn't really smart, I suppose. It caused me some pain, but it created a sort of platform for me, I think, to start to move into a different form of maturity around my spinal cord injury and my pain and my implications. I set some goals around walking longer distances, and went through a phase of the next few months really pushing myself to see what my body could do in terms of that, I guess, just pushing through a bit of pain again to try and make the most of what I saw as a limited time frame. So I think maybe some people on the call would understand that for spinal cord injuries, you're typically told that you've got 6 weeks, maybe 12, where the bulk of your improvement will come, and perhaps 1 to 2 years where there'll be some level of improvement afterwards, and we'll only know by looking in the rear vision mirror. So I was 18 months in, and I basically I was punishing myself around how I felt, and thought, righto, I need to up the ante a little bit and push through pain a bit more and just take action now. Now, I think this is story sort of relevant to all of us, because we're all on a journey in life. It's never quite perfect, no matter how imperfect it is. It varies at different stages, but we all have levels of speed bumps that we've got to go through, or we support other people go through. And many of those journeys, those speed bumps, feature pain. So that's why I really wanted to concentrate on that concept that personal agency through pain can improve our outcomes in our life. And I firmly believe that from my experience. Now, I appreciate that all pain journeys are unique. My perspectives are just my own. Hopefully there's something you can reflect on out of what I say today, and I guess the way I've tackled things that might have some value for you in a future situation, a current situation. just to change your perspectives a little bit and find a breakthrough. But I do appreciate it may not, and everyone's a bit unique. Before I go on, so it's a quick self-intro. So Mark Berridge, father of 3 delightful now adult children, youngest in year 12. Lovely wife Lucy, who was incredibly supportive during my spinal cord injury of March 2019. My life changed the moment I went from being a senior sales and marketing executive to feeling completely helpless just in a split second. My bicycle lost control through a corner, just hit a sunken piece of road. I regained control, but had to make a controlled crash decision. And I went flying over the handlebars, hence being an accidental author, smashing into the ground, fracturing a left wrist, crushing the helmet, fracturing left scapula, 3 ribs, but most materially crushing 2 vertebrae and compressing my spinal cord by potentially 80% from what I was told afterwards. You can imagine that a bit of pain came with that. It was a pretty tough situation. But I guess they put a fixation down my back for a year of some rods to give me some sliver of hope of walking again, and I managed to navigate my way forward from that. And all of those, I guess, actions sort of set me on a path of writing and sharing and having opportunities like this to be able to share my story. So I'm very grateful for that. And through that, I did have to navigate a lot of pain, and that's why I feel like that personal agency during pain is so powerful. So what do I think I did? Well, most simply, first and foremost, coping. Like, I think in the very first instance of being in the ditch, when the pain was just so incredibly intense, what can I do now, right now, that helps me rather than become overwhelmed by this situation? Just breathe, because my breathing was so impacted by the muscles around my spinal cord injury contracting to protect it, because the body's so clever, from the fractures to my ribs. But if I just find a way to breathe, then I can just sort of stay in the moment and not make the situation worse, which is the most important thing for me in that moment. And then apply a bit of humour. So I was supposed to be flying to Salt Lake City for a work project that night. Obviously, it worked out pretty quickly. I wasn't going to get on the plane. So I started throwing around the joke, well, I guess I won't be skiing in Salt Lake City next weekend, boys, which I've been so excited to do. So, these little coping strategies, they were important to me very much in that first week, first few months. But they continue to be just helpful every now and then. What's the simplest thing I can do? How do I do that? What's the things that might alleviate me feeling about this pain or my situation? How can I do those? The coping strategies. My biggest strategy for a long period of time, and probably why I thrashed myself up that hill like some crazy man walking up Mount Griffith at 4:30 in the morning, lucky not to trip over, was progression through pain. And I think the physios helped me early on work out that I was in pain anyway, right? And just by doing the right movements in the right way, the pain might be slightly more intense in doing it, but I was moving forward. And that idea that I could sort of sell myself a trade-off of, I could push myself into that pain a little bit in order to get progression, and therefore eventually I would be in a better spot. That was very central to my recovery for a long period of time. And as I said, I think that was probably the most instrumental thing of throwing myself up the Mount Griffith in September 2020. But eventually I had to sort of get a bit more transformational, get into that acceptance phase of a more mature look at the pain and my situation. I think, how do I become a bit more sustainable at it? So I caused myself a lot of implications actually by walking quite heavily up that mountain and a few other activities where I really trying to push for as much, physical improvement over the last 6 months of this notional 2-year period. Ended up ending with a high dead muscle count in my blood. I always think of it as the CPK scores, how I remember what I was told, which I was basically getting, 4 or 5 times the typical average result of this dead muscle in your blood, because I was just pushing myself too hard. As context, a professional footballer, NRL, AFL or something I was probably coming out with results double what they might have at the end of a really intense game just from my normal activity. And as the neurologist said, Mark, for you, walking on the flat is like someone else walking up a set of stairs. So why the hell are you pushing yourself so hard up the mountain? But you can't separate mental and physical rehabilitation sometimes. And for me, that sense of pushing the boundaries was important to my mental welfare. So long as I pushed myself in a way that, you know, once I needed to, I recalibrated and go, okay, right, that was nice for a period of time to prove that I can do stuff and prove I can push through pain for gain again, but that's not sustainable. It's more like a sprint capability. Can't keep sprinting. How do I then tailor it back to be much more focused about my rehab activities for a period of time? And then if I need to sprint for a specific goal again, I'll do that again. And I think that ability to maybe sprint through pain in a way might help you move to a different perspective of it for a period. But again, you need to see, I think, that some sort of return out of that that's sustaining. I think probably all the way from the spinal cord injury event, but because I got so much amazing support, etc. But particularly, I think as I got into this more mature phase, that it was going to be around for the rest of my life, just practicing gratitude for what I could do rather than punishing myself for what I couldn't do. So, you know, that particular, you know, restless night and Father's Day morning, you know, I'm punishing myself for the gaps in what I can't do versus my previous expectations are, rather than celebrating what I can do now. And I think that ability to sort of celebrate what you can do, finding joy in what you can do is still valuable. And sometimes that's a little bit bittersweet for me. So, for example, I still love cooking. I'll still push myself to contribute to the family and contribute to my sense of well-being by cooking the evening meal, even though that's the sorest time of day for me. I know that short, sharp steps, that twisting, that the motions of cooking will always cause me lower back pain. How much of that's just perceived from my past experience, how much is real, I don't really know, right? But it's there all in those activities. So then how do I find, you know, the opportunity to really appreciate that I can still do it, and also reward myself with really enjoying the meal afterwards and reflecting on the joy of having created that, or rewarding myself in some other way, some other downtime, lying on the floor, rocking knees on a Swiss ball, or whatever it might be that's the offset. So when you're going to push your boundaries on one side or push something to a slightly more uncomfortable position in pain, how do you then provide that emotional reward, that mental sort of break with some sort of offset? I try and practice that strategy a lot. So yeah, so summarising those sort of ideas, like sort of, I guess, from coping to progression to a bit more maturity and a bit more selective about how I deal with my pain is probably, I think, the overall flow I feel I've done. And, you know, I think that was really important to me overall and in that event. And just going back very quickly to Mount Gravatt again, you know, for me, for a long time, I held up that mountain as being a little bit sacred. I love cycling there. It was one of my favourite spots in Brisbane to cycle. Going up wasn't so much fun, but yeah, felt the reward at the top. Coming down, I loved the freshness through the trees, around the sweeping bends, early in the morning. It was just special. And I'd held it there as a special thing for me to go back and cycle to eventually. But sometimes, you know, when you're dealing through a pain and a life change, you've just got to set that to the side and say, I'm never going back to that in that way. How can I take a different view of that mountain? How can I take a different perspective on my life going forward and celebrate the things I can do? And I think that's what I did eventually with that mountain. It took a bit of time. And I think for many of us, that's essential. It's just finding those sustainable ways to process, you know, progress in life, to process the pain or other things we're going through, and to continue to achieve and enjoy and make the most of life. And you know, hopefully I've been able to give you some perspectives on the things that work for me in doing that, and hopefully that helps you.
Thank you, Mark. Yeah, great insight, and good to hear your story. I've got a few questions coming through in the chat. At first, I'd quite like to maybe ask Lisa this one. Are there any messages you can give people regarding the difference between hope for a cure or improvement and desperation to fix this? And can you comment on the utility or harm of these thoughts and attitudes?
Yeah, so much to say, some great questions in there. I suppose what I simplified that long question to be is pain management versus pain cure. And I've made a lot of mistakes in terms of management that I can share so you don't make them. And that is that I originally thought I can cure this pain. So I spent far too much time, energy, effort going to every second acupuncturist, herbalist, thinking I could cure my pain. But one of the keys for me, and Mark touched on this, was acceptance. So it was a long time before my peripheral neuropathy, as a result of my brain hemorrhage. It was a long time before my peripheral neuropathy was diagnosed. So originally, all sorts of specialists thought it was tight tendons, tight ligaments. Somebody said it was a fusing of my ankle that needed to happen. So it was only when, by pure luck, that someone said, no, this is peripheral neuropathy, that I realised, having read up on it, that I can't cure that, so I just had to learn to accept that. But there's been other pain, my hip, for example, I was in chronic pain with that. But hey, what do you know? Hip replacement at 27 did fix that, but different sorts of pain are so different for everybody. But assuming that we can just fix everything, or need certain sort of interventions that work for somebody, doesn't mean that it's going to work for you. But be an advocate for yourself as well. Do your own research. And I say that with don't go on Google, but scientific literature, professionals like we have here today are really good resources to do your own research and take that to your pain specialist as well. So definitely be your own advocate. And in terms of creating an identity around pain, it sounds a little bit naff, but I'm not my pain. There's so much more to me than all the pain that's going on. And something that I learned fairly early on was that, as wonderful as online resources and focus groups and support groups and peer support can be, it can also be really dangerous in some cases, not all. But if everyone's sitting around talking about how horrible pain is, that's just, the mind is so powerful, sending a subconscious message to you all the time that yours must be shit too, because everybody else's is. And it goes back to that old saying that it applies to everything, whether it's business or parenting or pain. You are the 5 people that you surround yourself with. And if you're just surrounding yourself either virtually or in person with these negative messages about pain and everything like that, then that really does start to have an impact on how you see your own pain.
Thank you, Lisa. I think one of the interesting points in there for me is that when we're trying to fix something, it is continued to be seen as a threat. But if we can accept it with kindness and make space for it in our attention, it can be de-threatened to a certain extent, and the pain experience can be lessened. Hannah, you've got your hand up, and maybe you've seen the question there. I'm not sure.
Thanks, Nick. I was just wanting to talk around a point that I think has come across from everyone's wonderful presentations this afternoon. One of the tools, I think, Nick, you talked about this concept that pain is a protective phenomenon. And when we're working with people and supporting people with pain to move forward, one of the really useful tools that we can use in the clinic is this concept of the protector meter. The protector meter looks at this concept that we have dangers, which we talk about DIMS. Our dangers can be in many, many places. It can be the things we do, the things we think, the places we go, the people in our world. But we can also have safeties, which we talk about as our SIMs. And when we think about pain as a protective phenomenon, we want to try and shift the balance between having so many DIMs in our world with what we're doing, what we're thinking, things that we're engaging with people in our lives, and try to add more SIMs. So we're shifting that balance and decreasing that protectiveness. We recently did some research around looking at what people in pain have as their DIMs and SIMs. And Kim, it was really interesting hearing some of your work that you've done as well, because the common types of DIMs or dangers that we found people had were activities that they were doing that were increasing their pain, the sensory feelings within their body that were increasing their pain, negative social environments, and also interactions in the healthcare setting. These were the most commonly sort of DIMS that were increasing people's protection. But Mark, your talk was just talking so wonderfully about what we see and what we might call the SIMS. And so in our research, what we found that those active self-management strategies, that personal agency that you were talking about, is one of the things that can decrease our protection. Positive social environments, doing enjoyable things. So talking about, you know, that value of cooking and weighing up, and our positive self-talk. So that attitude of gratitude that you were bringing to the things that you were able to do. So I just thought that for both people living with pain and the clinicians that you're working with, if you can really, a helpful way to get moving is trying to look and evaluate where are my DIMS and what could I start to change with those, and how could I add more SIMS into my world as one really helpful way with pain management.
Thank you, Hannah. There's a question for Mark here. It says, can I ask if pain medication played a large role in your pain journey, or whether you found that other non-pharmacological strategies helped reduce the need for strong pain meds?
Yeah, thanks, Nick, and thanks, Christine. I started typing out a response. This is much easier for me. At the very start, Royal Brisbane were just awesome. They had some social worker type pain specialists come around and really chisel at where I was feeling my pain and how to best direct the pain medication to support me. So that was really important at the very start. I think then I went through a phase of partially just wanting to get back to I was driven by this identity of the previous me of how do I get off all the pain meds as quickly as possible. But I had one of the physios very wisely say to me, Mark, I'm going to continue to push you really hard every week because you want improvement. You're going to be better off if you get this right level of pain meds, which for me was mainly around pregabalin, to help you manage that sort of, I guess, fatigue, energy, so that we can keep pushing you in rehab. So I guess where there's a real, sense for it. So I've continued on to a small dosage, all through the 5 years. So yeah, I guess talking through those pain meds, and for me, that's been the main thing. I haven't gone down the path of naturopathy or other things I could have, and I probably don't understand pain well enough overall, which I've thought about doing at different stages. But definitely, just physios and talking through my physios weekly has been my biggest factor, I suppose, in terms of managing pain, and also the sessions I had with the neurologist when she checked out my damage. And yeah. So that answer the question well, Christine, hopefully.
Yeah. Kim, you've got your hand up.
Yeah, just to echo that in terms of strategies, because one domain of my survey was also asking about what people currently or have previously used in terms of management strategies, and then how effective they found. And so I think this is a really important message to get across, is that there's always something to try, and in pertaining to especially like active strategies. So I will also say, if you've tried something previously and it wasn't effective, pain is this malleable plastic experience. And so I would suggest, if you have a trusted healthcare professional, you can always revisit active strategies. So physio, occupational therapy, psychology, I think is really important to link in here. There's whether a piece of equipment might be suitable, whether there's certain meditative or spiritual or religious practices, these things that are really upping the SIMS in your life, I think are worth not just investigating once, but checking back in with them. We found a lot of there's 11 different kind of domains of management strategies that I think would there's just lots to try, and the nature of pain being so changeable means that if you try something once in a certain way, I wouldn't write it off forever, in particular if it's an active strategy.
Thanks, Kim. Maybe I might just add a little bit there. There's not much evidence for any medications in long-term chronic pain, but they can get you through a difficult time for up to maybe a few months, depending on the medications. And low doses of low harm medications long term are probably not too bad, but yeah, so it's definitely not something to rely on for the long term as the first or most important part of your pain management. Do you want to have a brief comment on the VR and spinal cord injury question, Hannah? Then we might need to wrap up after that.
Yes, I just put a quick comment in the chat there. There are so many applications for virtual reality in healthcare, and I really think over the next 5 years, we're just going to see a big explosion of applications. We're specifically using VR around providing immersive education. So we know that having that understanding, like Nick was talking about, of how this pain phenomenon works gives us the tools to then have good pain management. And VR is an amazing way to really get that understanding. So by having that understanding and really getting to experience that people are having this courage to actually make changes, to take that step forward, and using your language you talked about earlier, Nick, it's about challenging those priors and doing something differently to create those new posteriors. So I think it's a really powerful tool that we'll see a lot more of in the next few years.
Right. And lastly, Kim.
Yes, I'll just make a quick comment because I think virtual reality it's another part of my PhD. So if I can just touch briefly or point someone in the right direction. I also see there's different thoughts about how virtual reality could be used. And Lisa in the chat has said that you've used so many meds and that did nothing but distraction therapy helped. I think that is definitely one element of how we think virtual reality helps. But if people are interested in learning more about specifically spinal cord injury related virtual reality for pain management, I spoke at last year's Hopkins Hour for National Pain Week, and I was interviewed. And so I would encourage people to go and find that on the Hopkins Center website or to reach out to me. I'm happy to, I won't give the rundown here because we've run out of time, but yeah, definitely watch this space. It's very exciting.
All right. Well, I'd like to take the opportunity to thank everyone once again. Mark, Lisa, Kim, and Hannah, you've been a great team. And thank you very much to the Hopkins Centre team for organising everything behind the scenes. Hannah Hears especially, and Makala Kerr working in the background there. So we've gone a little bit over the Hopkins Hour. It's a generous hour. And thank you all for attending until the end. We'll see you for the next Hopkins Hour on another fascinating topic. Okay.